Good evening, folks. Dr. David Rawson, founder and president of this academy. Welcome back. Happy New Year. This is our webinar number 28. We started in September of 2020, just as we're getting used to a thing called COVID, and here we still are. Christopher Schmid, Institute for Laser Dentistry, is North America's largest vendor-independent dental laser training organizations with thousands of dentists and staff trained across the country. Their programs comprise all procedures and all wavelengths, including safety, physics, and fundamentals, clinical indications for use, evidence-based research, practical considerations, and return on investment. Chris is a co-founder and director of research and innovation for the Institute for Laser Dentistry. He has over 25 years of experience in all aspects of laser dentistry. He lectures on the physics and fundamentals of multiple wavelengths and has performed thousands of chairside training sessions using multiple devices, including hard and soft tissue procedures. He's also hospital certified to train on laser technology across multiple medical disciplines in the operating room. It is very exciting to welcome Chris and his partner Gordon tonight to speak to you folks on minimally invasive laser treatments for snoring. Thank you, gentlemen, and welcome to our Canadian Academy. Chris.
And thank you, Dr. Rawson and Bianca, and welcome everyone. It's always a pleasure to share our knowledge and experience in the field of laser dentistry. And this is especially exciting because this is a very innovative procedure. And we are going to do our best over the next, let's say, 45 minutes to introduce this topic to you, to touch on some physics, fundamentals, practical issues, technical issues, and obviously to review a couple of clinical cases in an effort to introduce it and hopefully help you understand where it's come from and where it's going to in the future. And I'm certain that many of you are familiar with the surgical use of lasers in treating snoring. That has been around for quite some time. Laser-assisted uvulopalatal-pharyngoplasty, as it's referred to, or laser-assisted uvuloplasty, is not new in this field. However, we are going to talk about a modified version of that. So something that is new. And we are going to use the same technology, the same type of laser. We're going to talk about that. But we are going to introduce a different way to deliver the energy to the tissue. And that's called fractional laser technology. And what that does is it facilitates a minimally invasive procedure that we can do in the office in the absence of anesthetic. To the best of my knowledge, there have been no current documented adverse side effects. It takes about 15 minutes, and the results are extremely compelling. So I think it's an incredible opportunity for dentists to offer the treatment alternative to their patients. And the real benefit we have in introducing this to dentistry is the history of evidence-based research that we see across multiple medical disciplines that have performed virtually identical procedures for decades. And I'm referring predominantly to dermatology here, a very similar, if not identical procedure, which facilitates virtually identical metabolic processes, has also been very successful in gynecology. And that's a huge benefit to dentistry in really proving the clinical efficacy of these procedures. Now, that being said, in order to do that properly and do justice to that, I do have to go through some science, some histology, a little bit of physics. It's a little bit dry. It's difficult to make that too exciting, but I think that's the real value I can offer to you this evening, is giving you that background so you are comfortable and clearly understand how to implement these technologies, should you choose to do so, and what's happening in the area in the far field that we cannot visualize, because these processes are taking place beneath the epidermis, beneath the epithelium. So I really think it's valuable to explain that to you. Again, it's a little dry, some of it. I hope no one falls asleep. But that being said, if anyone starts snoring, I do believe I have a fix for that. So let's begin and talk about the history of the organization and get into some of the science and fundamentals. Okay, this is who we are, the Institute for Laser Dentistry, as Dr. Rawson has introduced us. Over 30 years experience, and we do perform a variety of didactics, hands-on seminars across the entire arena, focusing on all laser wavelengths and all procedures. We deal with all the different technologies. We teach on hard and soft tissue applications, ranging from general surgery to perio cases. We deal with hard tissue applications, osseous procedures. We've done a lot of work in the field of implantology, and unfortunately, recently are engaged in the field of dealing with peri-implantitis. And I will tell you that medical laser and surgical laser technology, in my opinion, is one of the most effective, least invasive ways to deal with peri-implantitis. So lasers give you significant advantages and benefits in operative dentistry. I find they do make difficult cases easier, and that has been our focus for over 25 years. And ironically, when we began, there weren't a lot of dental lasers, if any. So what we did is we took lasers from the medical profession and introduced them into dentistry. And I think that's really the foundation of our success. The experience that we've had across multiple medical disciplines prior to establishing the Institute for Laser Dentistry. And you can see the list of them here. And there is a plethora of evidence-based research we can draw on now in dentistry based on that foundation. And I'll give you just one example. If you look at the top left-hand corner of the screen, that happens to be a 600 micron lateral fiber, and we are doing prostate surgery. We're using, for that procedure, a 980 nanometer diode laser. Well, why are we using that? In this procedure, we require a laser that gives us very efficient and very effective vaporization of soft tissue with simultaneous and unparalleled coagulation. And the reason unparalleled coagulation is so important is we're doing this endoscopically. We're working through a cystoscope. And if we have bleeding, we completely lose our visibility. So this is a product that works extremely well in this environment. And learning from that, about 15, maybe 18 years ago, we introduced the first 980 nanometer diode to dentistry. Why? Because we needed the same type of functionality. We needed something that vaporized soft tissue effectively, efficiently, with very little, if any, inadvertent collateral thermal effect, which we know as necrosis, and durable coagulation. So that's just one example of how the medical foundation has helped us in dentistry. And there's others on this screen. On the top right-hand side of the screen, that procedure is called dynamic restoration of accommodation. It's for presbyopia. And we needed a laser that penetrated very, very shallow and in a controlled fashion. And for that procedure, we use an erbium laser, the exact same laser that we're doing anesthetic-free cases in dentistry. What we're going to focus on this evening is a laser that is depicted in the bottom two pictures. On the bottom left, that's an ENT surgery, which is a vaporization surgery. But the most relevant one is on the bottom right, and that is using a CO2 laser and a fractional scanner to stimulate processes beneath the epidermis for the purpose of tightening the surface of the skin. And that evidence-based research is completely applicable to what we're going to talk about this evening. So unfortunately, I am going to delve a little bit into physics. I am not going to show a lot of equations and graphs. I'm going to try to do it a little differently. But it's very important that you understand at least the fundamentals of qualitative laser physics. And why is that? We recognize that every dentist wants a preset. We completely understand that. And when we do chairside training, which is what we do after dentists purchase a laser, we work chairside with them on live patients and teach them the subtleties of the settings and the technique. We do give you a range. We do give you a starting point and a range. But what you have to understand is the laser is going to interact differently based on the characteristics of the target. So if we're working on soft tissue, it's going to work different if the tissue is blanched versus pigmented, hemorrhagic, desiccated. It depends on the original condition of the tissue. So the more you learn about the basic fundamentals, the easier it is for you to adjust your laser and be proficient in a very short period of time. So it is quite important. And if you've been to any courses in the world of laser dentistry, hopefully you've seen this phrase, selective photothermolysis, which is selectively transforming light into heat, literally put. And that is based on the fundamentals of the wavelength. It is the wavelength in particular that ideally defines the depth of penetration. And the reason the wavelength is so important is the wavelength is the one characteristic of your laser that you can't change. You can change the power, you can change the frequency of the pulses, the length of the pulse, you can change the delivery system. You can use different tips, you can use different fibers, but you can't change the wavelength. If you want to obtain optimal effect on target tissue, you do need to pay special attention to the wavelength of your laser and understand how that interacts with biologic soft tissue or hard tissue for that matter. The way we facilitate the interaction of the wavelength with what we call the target or the chromophore is based on absorption. The first law of photochemistry states that in order for laser tissue interaction to take place, we must have a photoreceptor molecule. So there must be something that absorbs the light and turns it into heat. If there is no absorption, you will not have any transition from photo to thermal. It will just stay light. So this is fundamental. Selective photothermolysis is fundamental, and the concept of absorption is fundamental. And generally speaking, the greater the absorption, the greater the interaction. This is how virtually every medical or dental laser works. And the reason I'm stressing that is the following. In dentistry, we're used to something like this. We're used to something we can visualize. What you see is what you get. We have a case where we may need to remove a little bit of tissue here. We definitely want durable hemostasis. We do not want any inadvertent lateral thermal effect beyond the zone of coagulation. We don't want necrosis here because we want to have predictable margins. We want to have an immediate impression. This is something you can see. You have the hand-eye coordination to visualize that. Any of these examples, when we're dealing with soft tissue, we want to plan our work and work our plan. We want to know our end point. And in these cases, we want to remove tissue perhaps in these examples, but not have too much heat, just enough heat to coagulate, enable us to do immediate impressions. And then when we fit for the final restorations, we have predictable margins. That is the magic of what we call wavelength specificity, having the exact wavelength that's important for the procedure and adjusting it appropriately. We're used to seeing that. We understand what we're doing because we can see what we're doing. But we're going to take a step back here for a minute, and I'm going to illustrate something that's more relevant to what we're going to do today. we are going to talk about taking that laser energy and not working in the near field, but working in the far field, in an area where we're actually not going to be able to visualize the effect of the interaction, not immediately. And it's similar to what we're doing here. This is panretinal photocoagulation. So we are photocoagulating the retina for the treatment of diabetic retinopathy. Well, in this case, our wavelength of light has to go through the vital organ and become photothermal in the far field at the back of the eye where the retina is. So how do we do that? There's two fundamental criteria that we have to pay attention to. The number one is the wavelength. Again, it's the most important. This happens to be a 532 nanometer visible green wavelength. But number two, even when we get the right wavelength, we need to be able to control it by our mode of operation. And that's what we're introducing tonight as fractional technology. It's different than what you're used to if you're using a laser today. It is not a sapphire tip. It is not an optical fiber. It's a completely different technology, which gives us the control to direct that wavelength deeper into tissues. So that's the science we need to keep in the back of our mind as we evolve into the world of lasers and snoring. And that's where we're going to go now. So here's the general introduction and objective of this evening's seminar. We are going to introduce you, to the best of our ability, to this concept of a minimally invasive laser procedure as an adjunctive therapy to the treatment of snoring. We are not implying that it replaces modalities or treatments that we're using today to treat snoring. This is complementary and adjunctive to that. And it's also important, I think, to point out, while there is a link between obstructive sleep apnea and snoring, in that the majority, if not all people who are diagnosed with OSA will be snorers, it isn't necessarily implied that everybody who snores has OSA. So we're not going to focus in depth on obstructive sleep apnea per se. We are going to focus on treating a symptom of that, which of course is snoring. So let's begin with a basic definition that we all agree to, snoring being an acoustic effect that occurs during our sleep. And fundamentally, what we're going to focus on this evening with the laser treatments is the result of the vibration of the flaccid soft tissues of the nasopharynx. So this is what we're going to focus on as a treatment area, particularly the soft palate and the uvula, excuse me. We're going to talk about treating other arches as well in the base of the tongue, but it is the soft palate and the uvula which are our main targets for treatment. Let's talk a little bit about the incidence of snoring as well. As many as 90 million Americans report that they snore at one time or another, with 37 million saying they snore regularly. It affects 57% of men and 40% of women. So pretty high incidence in the population that we see in our dental practice virtually every day, every week. And I think that dentists are ideally positioned to play a very important role in the treatment and the care of their patients in regard to treating snoring with this very minimally invasive procedure. The contributing factors, when we get into a situation where we're introducing technology, we like to set realistic expectations. So let's talk about what we know are the contributing factors to snoring and where we can offer benefits in order to set those expectations for our patients. We already talked about OSA and treating snoring as a symptom of OSA, so we're going to talk about that. I am going to show you some clinical cases, uncontrolled studies this evening where patients have been diagnosed with OSA. But there's some other contributing factors, some of which we can deal with and some of which, of course, we cannot. We are not going to talk about affecting things like allergies, seasonal flu, and sinus infection with these laser treatments. Obviously, deformities such as deviated septum and nasal polyps while they can be dealt with, polyps, of course, with laser technology, we're not going to focus on that. Poor muscle tone in the throat and tongue. It is interesting, and I will refer to this, when we cause a shrinkage or a tightening of the soft palate, and of course, a rise of the soft palate towards the hard palate, necessarily we put more positive pressure on the underlying muscles, which are, of course, are affixed to the hard palate. So in doing that, we do see a repositioning of the tongue and an increase in airway volume and flow. So we are going to talk a little bit about that. Bulky throat tissue and large tonsils, of course, and adenoids are other things that can contribute to snoring, which we're not going to focus on. It's predominantly the soft palate and the uvula. Those are the fundamental areas of focus for this treatment. Other contributing factors, which hopefully are temporary, other than genetics in this example, we also educate our patients on, and I'm not telling you anything here you don't know, but we do like to be very candid about setting clinical outcome expectations and what affects those. So this is part of the patient education process we go through when we talk to people about using these laser treatments for snoring. So what's our alternatives? You know about these as well. I'm not going to focus on these in any great detail. Obviously, diet and lifestyle make a big difference. I would say the second most common solution that we see in the dental practices today are custom fit oral appliances, which I'm sure you're all very familiar of. Compliance issues here sometimes, but they work very well. And of course, the gold standard of treatment being CPAP for OSA. None of that changes. We are adjunctive to those different therapies and complementary, hopefully, to those therapies. The thing I introduced that we traditionally have done with lasers, which is a surgical procedure, uvuloplasty. We're also not going to talk about this evening, but we are going to talk about a modified version of that. This procedure, of course, involves the actual shaving and removal of soft tissue from the soft palate and the uvula. It is a known procedure, an established procedure, a procedure that works. But of course, the more invasive it is, the more we risk impairing function, the more we risk longer and complications sometimes associated with recovery. So we're going to focus on something completely different today. We are going to ironically use the exact same laser, but we are going to change the delivery mechanism. So we are going to move from a traditional beam profile, and I'm going to go into this in some detail, and we're going to move away from traditional laser technology beams into fractional laser delivery. So this is a minimally invasive procedure, which is a modified version of a laser-assisted uvuloplasty. It is minimally invasive, and we're mainly focusing on dealing with palatal flutter. That's the primary focus. We're trying to tighten up the soft palate and eliminate the flutter that is found to be the most important factor in the mechanism of snoring. We're going to focus on shrinking back that palate. We're not going to shave it. We're not going to cut it. We're not going to do anything surgical per se. We are going to facilitate or stimulate natural metabolic processes beneath the epithelium. So we are going to introduce something we refer to as controlled thermal injury. Injury can be a good thing in the metabolic system as it relates to this procedure, as long as it is specifically controlled. Because by controlling thermal injury, we can stimulate a natural healing process. And that's exactly what we're doing here. And the healing process comprises collagen remodeling, number one, or collagen shrinkage. And number two, the creation of new collagen, or neocollagenesis. The result, visible elevation of soft palate tissue and uvula, tightening of the overlying tissues, and this is what gives us our increased upper airway volume. Where are we getting the underlying evidence-based research in science to facilitate the clinical, to validate the clinical efficacy of these procedures? Other medical disciplines who have performed similar, if not identical procedures in the past to give a very similar, if not identical outcome. So the gold standard for doing these procedures has been fractional laser delivery for many, many years. And it involves laser irradiation going deeper into tissues, which then stimulate natural metabolic processes and morphological changes. And we're going to go into that in a little bit of detail. The result is, by building up the substructure of the skin with the elasticity of the surface of the skin, if we build up the underlying layers, necessarily we stretch the surface over a bigger layer of tissue underneath, and that's what smooths the tissue. That's how we do wrinkle reduction on the face. It's exactly the same thing. And we are going to emulate that process on the soft palate with an identical technology delivery system. Let's look a little bit more detail into fractional. Formal definition here, obviously relating to or being a very small part of or inconsiderable part of. What you're used to doing if you're using a laser technology today is making a much larger spot of energy delivery to the tissue, right? We're using a large fiber or a large sapphire tip. And by that, I mean maybe 400 or 600 microns. What we're going to do now with fractional laser technology is we are going to deliver our energy over something called microscopic treatment zones. We are going to very precisely control, first and foremost, the diameter here, or if you will, the width. So these little microscopic treatment zones could be something like 150, 160 microns, a fraction of the diameter of your eyelash. We're going to control the width, the depth, and as importantly, and this is the key, the density. That is the spaces of untreated tissue between the microscopic treatment zones. And it's those areas of viable epidermis and dermis that allow for the rapid repair of the tissue. So we're putting controlled thermal injury into the tissue on purpose to stimulate the healing response. A couple of different ways we can deliver fractional laser energy, just so you understand it a little bit better. I'm not going to go in depth into the technology here, but you see a traditional laser beam on the left. And if we would put a focusing lens in front of that beam, necessarily we can split up that one beam into several microbeams. So that's one way. It's called simultaneous fractional delivery to deliver fractional energy. Of course, we decrease the intensity by splitting the beam up into multiple beams. It allows us to go deeper into tissue without any adverse effects on the top of the tissue. A more effective way to do that is to use a scanner, which actually delivers individual beams of light. We don't have a lens here. We deliver the beams very, very quickly in microseconds, sequentially. And by doing it sequentially, we don't deliver them all at the same time, and we can change the position of where we deliver them to maximize the viable tissue between the spots. This allows us to put more energy in per spot, generating or facilitating a better result at lower risk. So it's the most sophisticated way to deliver fractional laser energy into tissue. Just to bring this part of the science to the close, if you will, traditional ablative laser technology or skin resurfacing that you see on the left actually removes the surface of the tissue, the stratum corneum. It gives us a good result, but it removes large areas of tissue. With fractional, we can have an ablative or a non-ablative process. And the only thing I'll talk about there is the difference between the two is non-ablative just puts heat into tissue, and ablative actually makes those little micro incisions that I depicted a couple of slides back. And in that respect, we are actually able to stimulate a better healing response, which gives us a better result and a longer term result. So the ideal way to do this is to deliver a fractional ablative process using a scanner and sequential delivery. That's the best way to stimulate the best result. So we're going to put these controlled zones of thermal injury into tissue, and we actually stimulate two processes. The first process is actually remodeling of the collagen, and the second process is the creation of new collagen, or neocollagenesis. And it's the initial remodeling that gives us a rapid contraction of the collagen fibrils. And that's where you will see an actual response immediately after the treatment. And I'm going to show you some pictures of that. Over time, we have a process of neocollagenesis because, of course, collagen doesn't build immediately. It takes weeks. It's sustained over months. So that gives us a further increase in stiffness of the overlying tissue, because when we build new collagen, which sits on top of old collagen, of course, we increase the foundation underneath the surface of the tissue. And with the elasticity of the tissue, we tighten it up. So this is exactly where we get the visible elevation of the soft palate, resulting in an improvement in the upper airway volume. Let's just touch base a little bit on collagen. I know you're familiar with it. It is the most common protein in the body, but how do the lasers interact exactly with this collagen? Okay, collagen creates the framework of our skin. As we get older, it depletes, which is how we lose the framework and get the increased laxity and elasticity, if you will, in the skin. And multiple studies have shown, as it relates to laser technology, by raising the dermal temperature above 46 degrees Celsius, we trigger the release of something called heat shock proteins. So what are heat shock proteins? Not surprisingly, proteins that are made when cells are briefly exposed to temperatures above their normal growth temperature. And as that relates to this specific procedure, we're targeting, and the histology tells us, and the science has proven to us, a specific heat shock protein number 47, because it is thought to be a molecular chaperone for the maturation of collagen molecules. So it facilitates the process, the very process that we're trying to do. Here's some histology. This is a ablative fractional process. And you can see microscopically here, 100 microns is the scale on the bottom left. We actually ablate a very small column of tissue. And you can see 2 days postoperatively, there is an invagination of the epidermis, which is quite visible. But 1 week post-op, you also see that there's a re-epithelialized epidermis. So very fast healing of this microscopic treatment zone that we have created. 1 month post-op, the invagination has regressed, and at 3 months, you see an improvement and an increase in collagen, newly formed compact collagen, which would have the effect of smoothing or flattening out the surface of the tissue. And this is a classic example of ablative fractional photothermolysis. This slide just shows us that with increased energy measured in millijoules, we will get, of course, an increased defect and necessarily an increased result. So in doing these treatments, it is a balance between how much energy we want to put into tissue, which can be infinitely controlled. The more energy, the greater the depth into the tissue, the better, if you will, the result. And we can control that infinitely with these fractional scanner technologies to give us the desired result. And that's really what we've seen in the science dating back decades in the field of dermatology. Our target here in dealing with the oral tissue is the lamina propria, which is a little deeper. We see here where it resides. And that's because the lamina propria has large concentrations of organized collagen. So by targeting that area, we not only get a better effect, but the science tells us a longer lasting effect. And that is a function predominantly of the wavelength of energy we use. Let's take a cross section here of skin structure that we see on the left. And you see where the collagen and the elastin reside. And on the right, if you can see that, we see oral tissue with the lamina propria pretty well mapped across where we see larger areas of collagen. So that's really the target for these laser treatments. I have one more set of histology here, and then we'll get into some clinical examples. Here you see at the top left, normal organization of the lamina propria and the collagen, of course, becoming less dense as we get into the submucosa. On the picture on the top right, immediately after the treatment, you do see a mild focal erosion, and you see a bit of a disruption of the lamina propria here. But 21 days postoperatively, you will notice with the red staining a significant increase in collagen bundles. Albeit they're disorganized, there is a significant increase. And as we go to 35 days post-op on the bottom right, you see not only is there sustained increase in collagen, but this collagen now is organized and it's running parallel to the epithelial surface. And that is classic to what we see in dermatology as well, in the process of fibrosis, if you will, in healing that tightens the surface of the tissue. Okay, thank you for your patience in the science. I'm now going to move to some clinical cases to visually show you what we see when we perform these treatments immediately and after a period of time. And in order to evaluate the result visually, since we're not going to be able to see beneath the epithelium, we're going to measure it by standard Mallampati classifications. Here's a picture of a fractional laser delivery system. This is the aiming beam. The laser technology that we use here is invisible, but you have to have an aiming beam in order to obviously see where on the treatment area the laser is going to fire. And you see different densities here. I talked about increasing and decreasing the density on the different tissues. The closer the spots are together is a higher density delivery, and the further they are apart, where we have viable tissue between the spots, is obviously a decreased density. And for the targets, we've talked about this. These are the areas that we're going to target. Mucosal soft tissues, typically soft palate, uvula, and the back of the tongue. Those are primary target areas. And in the studies I'm going to show you right now, the case studies, they are controlled studies, they have mapped out the exact treatment areas. So you can see here on the diagram 2 and 4, the soft palate and the uvula, 1 and 3, the palotoglossal arches, 5 and 6, palatompharyngeal arches and tonsils, and 7 and 8, the lateral part of the tongue. Now, this is also where you will learn about the difference in coverage and number of passes. If you're doing something like this with an erbium laser technology, which is very shallow penetrating, you do require multiple passes, at least 3 in the examples we've seen in these case studies. If you are using a CO2 laser with a fractional delivery system, it is a single pass of the entire treatment area based on the superior depth of penetration of CO2. That's the biggest difference between the 2 wavelengths. So here's an example, pre-treatment class 4, immediately post-operatively, and we have treated all of the defined treatment areas, and we've done it over 3 passes on this one example. Immediately post-operatively, we see an improvement to class 2, and that's due to the reorganization of the collagen as opposed to the creation of new collagen, which of course we can't do in a 15-minute procedure. But you do see here, after 3 treatments, we get a further improvement to class 1. There is no visual on the palate here. You don't see the interaction. There is little microdots you would see if you actually did it on your hand or your arm, but because of how hydrated the palate is, you aren't able to see, which is why it's so important to have the aiming beam and to know you're covering the entire treatment area. This is a study that was performed in Europe, I believe, and it's interesting that they looked also at the amount of oxygen in the blood. No significant difference before and after, but some of the patients did have significantly better oxygen scores in this example. I'll show you a couple of other examples. Pre-op class 4, this is a 36-year-old female diagnosed with OSA. After 3 treatments, so this would be 3 treatments at 15-day intervals, improvement to class 1, and at 36 months, in this case example, regression back to class 2, but still a very compelling result. Another example, pre-op class 4, after 3 treatments again, very similar treatment protocol here, class 1, and sustained at 36 months. This is a 42-year-old female diagnosed with OSA and using a CPAP device. So this is a classic example of an adjunctive therapy to help out in the treatment of snoring in particular. I'll give you one more example here. This is a 30-year-old male. I believe this is a hockey player diagnosed with OSA using a CPAP device as well. And you see the results here, pre-op class 4, post-op class 3, exact same treatments. And after 36 months, post-op 3 treatments, sorry, class 1, and after 36 months, sustained at class 1. So quite compelling results for an office-based treatment. And let's look at the summary. These treatments are typically 15 to 20 minutes. They are performed in the absence of anesthesia. And it's arguably a faster treatment if you're using CO2, because of course you only have to do 1 pass. And that's the difference in the number of treatments between the wavelengths. It depends what wavelength you're using, and that defines how many passes you have to do of the target area in order to maximize the outcome in a safe and effective manner. The patient scores are extremely high in these studies. They're recorded upwards of 85%. In those studies as well, there have been no documented adverse effects. It's interesting that there are immediate as well as lasting results. And while this is fairly new, the lasting results are quite compelling as well. But it is important to acknowledge that these are uncontrolled studies and always need to do more studies in something as innovative as this type of procedure. So let's talk a little bit now about the different technologies that we can use. CO2 and erbium will both be able to deliver results in performing this procedure as long as they can be delivered through fractional laser technology. So we can break up the energy in little microscopic treatment zones. Based on the history of dermatology, of course, CO2 is still the gold standard for fractional thermolysis. And that's predominantly due to the fact that we get a superior depth of penetration, if you will, in a controlled fashion. And that's where larger concentrations of organized collagen are present. And that's our target. And that gives us a better immediate outcome and a longer lasting effect. And that is a function of the wavelength. Again, we're targeting the lamina propria, which you can see by this diagram, and the histological diagram on the right as well is a little bit deeper into tissue. And if you want to look at an actual depiction of the difference in depths of the two primary wavelengths we're using here to perform these procedures. You can see it on the right here. Erbium is 2940, and there is a range for the CO2 wavelength. And you can see that there is, all other things considered equal, a different depth of penetration. Now, that being said, just so we put this in perspective, CO2 depth of penetration, in biologic soft tissue is still relatively shallow, typically under 200 microns, but it's at the right depth to stimulate the metabolic processes that we're looking for. Okay, let's talk a little bit about numbers. I usually leave this to the end, but of course it is important, so we'll talk about it now. The market rate for snoring, this is a cash-based procedure, is between $650 and $700 US per treatment. And again, we're requiring multiple treatments. I typically would do one with the CO2, but I split the difference here from a financial perspective. Erbium is 3, CO2 is 1. So you're going to require perhaps a couple of treatments. And in that respect, 2 treatments per month, if you want to look at the investment in the technology, 2 treatments per month would pay for the laser devices that are performing these treatments. Now, over and above that, the good news is these same lasers do multiple other procedures. And I've just put a list together of soft tissue procedures. This is based on US dollars and US billing codes. But these soft tissue procedures, which are common in a general dentist's office, can be performed with the same laser technologies, any of these soft tissue procedures. So if you're in a position where you are considering investment in technology, I think you owe it to yourself to look at a list like this and see how many of these procedures you might see in a week or a month, and how many you might do. And most of them are basic soft tissue procedures. But if you get into some of the periodontal treatments, the adjunctive therapies with doing soft tissue work with implants, and of course, peri-implantitis, it adds up fairly quickly. So I would take a graph like this or a list like this, and I would just fill it in. And I mean, I filled it in with some examples here. And in doing that, I've come up with about $6,500 of net incremental revenue over and above the snoring treatments. So if you would do half of these, then maybe you do 3,000. But in all cases, the dental laser investment should add incremental revenue to your practice, not necessarily cost. In closing, I always get this question, so I add it as my second last slide, I guess. Do these fractional lasers, and are they capable of working outside of the mouth and doing things like fine lines on the upper lip? Absolutely. You know, this is something, that's what these CO2 lasers were invented for. And that's always a question that comes up. So of course, it's the same technology with the same scanning technology. So I know some dentists are involved in the administration of Botox, Restylane, fillers, et cetera. And we do that, you know, we do get those questions. So it is the exact same technology. And that concludes the formal version of my seminar. I know it was fairly quick, some parts of it, and I tried to cover quite a bit of detail in a short period of time. So I hope it was informative, and happy to answer any questions or hear any comments that people may have.
Well, thank you, Chris. That was an awful lot of information, but very, very helpful and informative. So we thank you for that.